I'm gonna talk really fast now. So it's covering diseases of the vitreoretinal interface. So one thing we talked about a minute ago is medicine and changing world. As I said before, medicine used to double. Medical knowledge used to double every 50 years. Now it doubles every 3 months or so. And what we're not covering is on the left, but we are covering these things, which are all things we commonly see in the office. Staging is important, I think. With OCT scan, we're able to stage things, and I do that in my notes. So I stage all these diseases when I see a patient. Helps you assess the vitreoretinal maculopathy. Helps you assess the disease severity. It helps you to treatment plans. So you'll see it's easier to plan things when you see the stages, kind of where they are, where they're going. It's better for prognosis. When something's, depending on where it's at, it's easier to tell what the prognosis is. I think it's important for communication. So when I pull other people's charts and you guys are in residency, it's going to drive you crazy. I mean, it's so nice to get out of residency when you have your own patients. It's just, residency is just bonkers, where you just see all these patients that are new every 2 seconds to you. Clinical trials, we do a lot of clinical trials, and where they're at is important for clinical trials. And I think monitoring progression is a big deal. And also resource allocation, but I took that out of there, and risk stratification. So I think staging is important for several reasons. So we're gonna talk about the stages of these diseases. All of them have stages, which I think are pretty good now. As time's developing with OCT scans, sometimes there's multiple stagings. I'll talk about that a little bit, but people are starting to settle on a couple. It tends to be the simpler stages. Posterior vitreous detachments, age-related degeneration of the vitreous. The synchesis is liquefaction, syneresis is collapse. I believe these are in italics in the textbooks, unfortunately, so it's probably something one hurt to know. If you have any room in your brains. And then it's uncommon when you're younger. Fewer than 10% of people under 50 get this, but when you get older, it's common. So over 70, 60% of people get it. Although it's funny, you'll see people in their 80s and 90s who do not have posterior vitreous detachments. But mostly it happens around 60, 70. I've had it in one eye, I think. I don't go for eye exams. I just get macular scans once in a while. And so it's absolutely terrible. So I got my macular scan. I was like, oh shoot, I had a PVD. I was totally asymptomatic, like Zippo, no symptoms. And I don't know when it happened, which is nice. And so I had to get a checkup. It's accelerated with cataract surgery, inflammation, trauma, vitreous hemorrhage, and axial myopia. That's why there is a risk of retinal attachment. Probably half the risk of retinal attachment with cataract surgeries is inducing a PVD. And you'll see that with inflammatory diseases. So untreated uveitis, there's a risk of retinal attachment, which is brutal. Retinal attachments and uveitis are bad. So there is a staging system for PVD. And it goes like this. 0 is completely attached. 1 is a little bit detached. So when you do the OCT scan, you'll see a little bit of separation, but not a lot. 2 is just attached at the foveola. So it's detached everywhere but the nerve in the foveola. 3 is attached at the optic nerve, but off everywhere else. And 4 is detached from everything. And these are of some importance because, so what I do in my charts is I don't say stage 2. I think that's when my discussion, I'd say there's a stage 2 PVD because that assumes knowledge. Everybody else has knowledge. You can program your charts. So what my charts say is there's a stage 2 PVD, the vitreous is attached only at the foveola. So I have the staging in the description. So if you go to do your charts, I would do that. And then when some other doctor looks back at it, they can say, so for example, if someone has a macular hole in one eye, and they call you one day and say, what's my risk of macular hole in the other eye? And you look at your chart and it says there's no PVD, you can say 10%, but if you see there's a stage 2 PVD, that means that there's a 50%. So it depends on the stage itself. When it's stage 4 PVD, it's 0. And that's without looking at the patient, it's just looking at the chart. Whereas if all it says is no PVD or PVD, then you can't do that. So here's examples. So this is a stage 0. You can see the vitreous on your OCT scans. I would say 90 to 95% of the time you can tell the vitreous. But it's interesting. There was a paper just came out in one of our many journals. It wasn't a great one. It might have been OSLA Retina, where Seabag who's the vitreous guy. There's a book called The Vitreous by Dr. Seabag. He's out in California somewhere. He's like Dr. Vitreous. And he said if you look at the publications, he feels there's only a 50 to 60% chance you can call it PVD on OCT. I think that's low. I think it's 80 or 90.
Too. I don't know if that was the same paper, but he said the B scan was the most accurate.
The B scan, everybody says the B scan.
Which I thought was kind of,
yeah.
But I can really tell on this.
I can tell almost everybody. Yeah. Having said that, I did a macular hole last week I was sure there was a PVD, but I thought, I'm gonna put some Kenalog in, and there wasn't. Which was good.
So sometimes when it's just attached to the nerve,
Yeah.
it's hard to see
So this
sometimes
was
that
everywhere.
vitreous.
This was the whole macula.
Yeah,
I just couldn't see it.
Yeah.
It was weird. And they say in high myopes, it's hard to tell. They say in high myopes, if you're doing a vitreous surgery, you gotta put a little Kenalog in no matter what, because there'll be this vitreous pieces. So I'd say 95% you can tell. So this is the vitreous completely attached. This is an okay example. You can see it's starting to partially separate. I can point, I think, yeah, right here. So it's starting to partially separate a little bit. So it's a little bit detached, not much. So that would be stage 1. This is what you see a lot. So stage 2, you can see the really nice reflection of the vitreous, except for the foveola. It's just kind of pulling up everywhere. Most of these people are asymptomatic unless there's pathology. Stage 3, it's just attached at the nerve. So you see the nerve attached and then it's pulled off the foveola, which is kind of nice. It's interesting when you see these types of partial PVDs, you often see a little bit of extra tissue over here in the middle, which is probably has to do with the vitreous and the fovea pulling a little bit of tissue off. And you can end up with a lamellar macular hole or something like that. And then stage 4, it's completely detached or you're not seeing it. And you have to get a scan that shows the optic nerve to see that. Our scanning protocols for, I think, all the offices include a high resolution horizontal and vertical line scan through the macula, so you get the nerve, also for teaching. But, so those are stages of PVD, 0, 1, 2, 3, 4. You can put it in your notes, you can put it in your chart, but if you do chart it, I would make a macro that says what you're talking about, because most PVDs are not in common use right now. And I think that's it for PVD. Any questions? And we're not talking this in other parts of the course, and you guys do a good job. There's risk of retinal tear, retinal detachment, all that stuff in PVD. Just so you know, the risk of tear and detachment is about 5%. I used to tell people 2%. I'm not sure it's 5%, but there's some pretty good publications
it's a
saying
wide
5%.
range. I mean, in the book, 'cause
Yeah.
I'm doing the next
Yeah.
chart, and the book is like 218, right? It's like a very wide range.
And we're in a referral practice. That's the thing, a lot of papers come out of referral practices, so they see higher. A hemorrhagic PVD, it's about 40 to 50 to
Yeah,
60%. It depends on whether you're on aspirin or not. Actually, one of the residents wrote a paper with me on that a long time ago. Matt, shit, I forget his last name. He's Winter. He's up in New York. Epiretinal membrane is the next one. Again, we're just talking about the disease, not so much the treatment. Avascular fibrocellular free retinal membrane. It's interesting. It's common. About 2%. 2% of people get it, less than 50, 20% over 70 at autopsy. Clinically, it's about 7 to 10%. So a lot of times when you see people with something, it's nice to tell them it's common. That way they don't freak out. So you'll say, it's amazing. 7% is also nevuses. People will say, oh my God, you have a macular pucker. It's like, no, it's pretty common. And then the etiology is interesting. It's either residual posterior cortical vitreous after a PVD or secondary to trauma. And I think it depends. I think it can be either of these. I think the idiopathic ones are residual vitreous. So what I tell people is if you take a label and peel it off a bottle and a little bit of the glue gets stuck behind, that's what a pucker is. And then that can undergo, I don't tell them this, it can undergo metaplasia and it can turn into myofibroblasts and it can contract. So macular puckers have all sorts of cool cells in them.
Oh, purple.
There's staging of ERMs. I think this is probably more
Oh,
important than
purple.
the staging.
8 Charlie 2.
One is like a nothing ERM. There's an macular pucker. You're just putting in the chart so you can code. It's not distorting the fovea at all. Those are very common. Loss of the foveal depression. Took me a while to find a good one. I actually just saw finally a lady yesterday I could put in the lecture where all it is just the fovea is not flat. Sorry, the fovea doesn't have a dip. Stage 3 is where the fovea gets dragged a little bit, but the inner retinal layers are dragged, but not the outer retinal layers. And stage 4 is disruption of the outer retinal layers. And all of these do have, there are papers that are starting to use these now, and they'll talk about visions with them. So this is a stage 1. If you look at the picture, there's just like a little membrane over here. So, the retina gets a little shiny at one point and there's a little membrane, but the foveal depression is still there. It's probably not visually significant. I don't like operating on stage 1 macular puckers. I don't think they're doing anything. Occasionally people really want it, or the referring doctor really wants it, which is a little weird. And if everybody wants me to operate and they understand the risks and benefits, I'll usually do it. Loss of the foveal depression, lady I saw yesterday. So this is just epiretinal membrane in the center and the rectus flat instead of dipped. Occasionally you'll see people with foveal hypoplasia. So you have to make sure that there's no ectopic inner, the inner retina, the layers stop here so that this should all be pretty dark. This is a crummy picture. This lady's corneas are bad. And then this is stage 3. So you can see the outer retina is okay, but the inner retina is being dragged all over the place from the pucker. And that's a little more significant. And then this is stage 4, where the outer retina is starting to pull up. And then this is all dragged all over the place. Some of these are funny. I saw a patient the other day I was gonna bring in as a stage 2, but the outer retina was actually affected. So sometimes, and you'll find symptomatically in all these diseases, anything that affects your outer retina, it's interesting, I guess I can point here and it shows it there. That makes sense though. Anything that affects your outer retina affects your vision more. So the retina can be all over the place, and if the outer retina is not affected, you usually see pretty well. If it is, you notice a dip there. This is a surgical video. Oops, you're not gonna get to see. I try to keep surgical videos to 2 minutes or less because people just don't have the attention span. So this was a 2050 macular pucker. That would be a stage 3. The retinal architecture is all dragged all over the place. That's my contact lens. I'm not a CME, so I can say that. Then we did a vitrectomy already. What I do is go inside the eye, you just grab them every. I have these videos up so I can show them to patients because people say, "What's the surgery like?" So I tell them it's just like peeling a piece of Scotch tape off a piece of paper. So you just kind of grab it, you peel it, and then just like if you're peeling something off the paper, you wouldn't like keep dragging it. You kind of got to re-grab. You don't want to shred it. You don't want to pull too hard on the paper. You don't want to whack the retina with forceps as you're peeling it because that's not good either. And then you just kind of gently peel it off. Lately, what we do, a lot of us stain again for tissue glue. Do you do that almost? Yeah. So because it does probably help. So tissue glue, leave it for a minute, you stain it. It's interesting. This one is not on the center of the fovea. I probably didn't have to peel this off, but you know, it's in there and you got the forceps in your hand. So, and there's some question like how big a ILM feels helpful. Do you need a bigger or smaller? That seemed a little bit small in the middle. So I just peel some of the ILM off. This person, of course, did well because you're seeing the video. So they were 2,200 and they came up to 2040 pretty quickly. So that's on average, people return halfway to normal, although this lecture is not about that. So for stages of VRM, stage 1 is the foveal depression is present, 2, loss of foveal depression, 3, ectopic interfovea, 4, the outer retina is disrupted. And like I say, it'll say in my chart, this patient has a stage 2 epirigonal membrane, there's loss of foveal depression. And then it's a discussion item. Surgery outcomes, I just threw this in here. This is interesting. There's so many papers on macular pucker and everything. This is what I say to people for almost every disease, because people kind of want to know how they're going to do. And this is true I think this is true of macular degeneration, macular pucker, retinal detachment. It's true of almost everything. Most people improve. So I'll say 90% of people improve some, 50% of people improve a lot, which I think is true, which means usually 20, 40 or better, pretty functional vision. You know, some people improve, but they don't get that vision. Only about 10% of people achieve normal vision, macular pucker surgery, and that's what everybody wants. So when your patients come in disappointed with 20/20 vision, they're disappointed because they're not seeing normally. And some people are really disappointed. So you'll bring them from 2200 to 20/20, and they're like coming in every week complaining they can't see well. And so you have to say at the beginning, only about 10% of people achieve normal vision. And then there are complications with macular puckers. About one, I think, and I've not seen this published. I've not seen this published. I have a lot of macular pucker papers. So people get scotomas. So when you peel the pucker, people get blind spots sometimes because of the tissue. And same thing with macular hole surgery for peeling ILM. So you can cause damage there. I remember when I first started practice, I had a patient with macular hole surgery where, anyway, I told her there was at that time, there was an 80% chance of the hole closing. And she closed and saw better. It was before OCTs, but not a lot better. And she said, "You said I was going to see 80% better." And I was like, "Not really." So people hear things. So it's funny, they're kind of scared because you're going to do surgery. They hear all sorts of different things. So it's nice to have it written down, say it. We have pretty good handouts too. I make a lot of my own handouts. It takes some time. And there's a retinal attachment risk with everything we do. We get second opinions, and these are all local surgeons. So anyway, before you start there's a lot of papers nowadays on macular pucker surgery, and I'm not supposed to cover this, but on macular pucker surgery where they have 20/25 macular puckers. People are taking in better and better vision macular puckers because the surgery is pretty clean. It's like, why not? People say, why not do it? And these are all patients I've seen in the last 10 years or 15 years. This is a patient on macular pucker surgery and sees 1/200 because it was a traumatic peel. It's a nice way to say it. This is a patient who had MacTel in one eye, and someone didn't realize that, and they did macular pucker surgery. So you can tell from the left eye, this slide here, with the crystals, there's MacTel, and it's a funny looking fovea, but some people don't know the diagnosis of MacTel, so they'll look at that and say, oh, there's a macular pucker in both eyes. So they peel the pucker. MacTel patients, I've seen only about 3 or 4, I have to say, where people have thought it was a macular hole, macular pucker operated, they all get less than 2400 vision. They do miserably when you start peeling at their retinas. This was someone who's had macular pucker, someone who removed the inner retina, also probably light pipe injury, if you look at the picture on the left. They were probably shining the light pipe on the macula a little bit too long there. And this was someone where there's all these holes in the retina. If you look at these are all Pinellas County surgeons. If you look at the scan, there's like all this shredded retina. And then the vision's hand motion from a pressure spike. So the center of the retina is removed, but it should be 1/200. And this person did detach. They stayed like this for probably 4 or 5 years and the retina came off and I had to fix it, which is a pain with a posterior hole. So those are all bad outcomes. So surgery can always end badly, you know, so I don't think there's any reason to do surgery unless you're super symptomatic. There's a reasonable chance it'll help you. Any questions about that?
I have a question about like peeling. Is it better to wait till like these membranes are a little thicker to peel it? Do they come off easier, or is there?
Easier to peel a thick membrane. I always tell people like Scotch tape versus masking versus packing tape. It's way easier to peel a thicker membrane, but there's a lot of evidence in macular pucker literature and macular hole literature that sooner is better. And sooner means a couple months, not a couple weeks. So generally, if someone's got a trip to Alaska, I'm like, do the trip to Alaska, do the surgery when you get back. You know, I don't want to do it right before or a wedding or something, you ruin all the pictures. But so you can wait a couple weeks. I think if I had a macular pucker, I'd want it done within probably 3 months, not 6 months. And it's not hard to remove them now with the stains. So you probably don't need to wait for them to organize, but you probably do need to wait. Like the only ones you see organizing like that tend to be the post-retinal detachment ones. So we'll do retinal detachment surgery. We're sitting there seeing the person, and all of a sudden this pucker is just growing, you know, in the back of the eye. It's like, oh, go get that pucker. And some of those are horrible puckers. I've had 2 detach the retina. They were so bad. They just puckered the retina right off. Those you want to wait a little while. But most of them, one of the tricks nowadays with macular pucker surgery is the tissue stains. So if you have a mild macular puckers used to scare me a lot worse than bad ones because they're hard to see. I mean, because they're transparent and they're right in the center of the fovea. So you're just going to grab that. And I have had, I mean, none of those are mine, but I've had some bad outcomes. Now with the tissue blue, it's like cheating because the internal membrane is under the epiretinal membrane. So when you get the internal membrane up, the epiretinal membrane comes right off with it. So if it's a mild pucker, you just put the tissue glue in, you kind of scrape it with the scraper, grab the edge, it comes off, and the pucker's gone. You don't have to think about it. So that's, I think, why people are doing milder puckers is because of the tissue stains. And I don't mind using ICG for macular puckers. I don't like it for macular holes, but I don't mind it for macular puckers. But we have tissue glue now. It's available in the US. Vitreomacular traction syndrome, it's like a PVD that gets stuck. So vitreomacular adhesion, there's no disruption of the retina. And then what happens, partial PVD, the vitreous sticks, and there's tractional distortion, macular edema, or foveal detachment. I didn't distinguish, but I think the broad vitreomacular adhesion is considered 1500 microns in the book, and then did that. But 1500 microns is considered broad, under 1500 microns considered not broad. Spontaneous resolution is about 50%, but there's grades of vitreomacular traction, so we're grading this. So far we did PVD, macular pucker, vitreomacular traction, we did macular hole in a little bit. Okay, grade 1, distortion of the foveal surface, grade 2, macular edema, grade 3, subfoveal fluid. So it's sort of like macular pucker, and the other thing is there's stages of macular pucker and stages of PVD, and there's grades of vitreomacular traction. So someday, hopefully, this will all standardize a little bit better. So this is grade 1. So there's a partial PVD, and the fovea is stuck, but it's pulling up a little bit. So you can see on the OCT. This person's vision's fine. Grade 2, there's macular edema. This person's vision's probably a little bit worse. It's not always that bad. And the fovea is being pulled up, and there's fluid there, but there's not subretinal fluid. And then this is grade 3, where there's subfoveal fluid. This one is somebody I did a surgical. Yeah, so this is a patient I saw, and she did that. So she started off here with the grade 1, and she was 20/30. She had cataract surgery, and then she comes back 6 months later, and she's 2200, and fovea's pulling off. Some of this could be pseudophakic macular edema, but it seems like a lot of it was vitreomacular traction. So I did the surgery. This was so this is, you can see the canalogous issue. So you stick the canalog and you can see the vitreous. You pull it. This one, it wouldn't pull off easily. So you're kind of peeling and pulling and peeling, and it's just not coming off. So, and it's even stuck on the side. So basically you just gently peel. And then at some point it does come, but at this point I didn't probably have to keep peeling like crazy. Here it comes off the center just a little bit there. And then, but there's still some posterior vitreous stuck. But as long as the traction, like we've got 360 traction removed and everything looks pretty good, you don't have to keep going. And you can go back if you have to. I have to say, I don't like going back on surgical patients much. You can see it's all stuck back. You know, if in most cases, if you're doing a macular hole surgery, this would just pop right off. So the vitreomacular traction eyes are a little bit different. And then I stain it again. It's like, you can see it, that's pretty good. There's nothing really there. We don't have intraoperative OCT. This would have been a case for intraoperative OCT. You can see though, it's still a little strandy back there, you know? So it's not totally free, but it's free enough. So I kind of left it. And then this is pre-op, as you can expect. There's a video. It looks really good post-op. I think they were 2030 or 2020. It's 3 months post-op. So the vitreomacular traction can do well. If the vitreous is really stuck in the middle, you don't have to pull it off. I think I've seen people lose vision after vitreomacular traction surgery, and I think people are too aggressive. Harry Flynn at Miami likes watching things. He drives him crazy. It drives me crazy when people get up at meetings. I've seen very famous people get up at meetings and advocate for early surgery. And one guy in macular puckers before they get bad. And it's like, why wait? You know, we don't wait for, pneumonia to get bad. We should, not wait for cancer. Why not do macular puckers? So people, I don't think that's right. So this was 436 patients. They were followed for up to 90 months, which is a long time. Was that like 7 years, 8 years? And so this is sort of what they do. So if you look at vitreomacular traction, only about 20% release. So it's not that common from release, which is true. I'm surprised. I'll see people and I see him, he's following for a while, it just sits there. Some of them improve with no release. That's not all that common. That's only 2%. A lot of them are stable. 50% of the study were stable. Excuse me. So it's very common for them to be stable. And then some of them worsen. Again, only about 6% worsen. So most of them will be stable. And then about 20% of them they did surgery on, which is about right. And everybody was 20/40 or better at the end of the study. So vitreomacular, none of these things are emergencies. Most of them are stable. I think it's true. Most macular puckers, I didn't put that in, but we'll do macular pucker later because of disease is a lecture. But prognosis on all these is pretty good. So the grades of vitreomacular traction, 1 is a little distortion, 2 is macular edema, and 3 is subfoveal fluid. And then myopic traction and maculopathy, it's not in the book, but it's just so vexing. I put it in here. It's macular retinoschisis, foveal detachment. Sometimes they have a macular hole, sometimes they have a macular hole retinal detachment. So it's not staged, but that's kind of where it goes. Why it happens is it's not uncommon. It's about 10% of myopic patients. It's either anterior posterior traction, or there's a rigidity to the ILM, or it's the staphyloma. And I think it's the thing that makes it so hard. I think in a lot of cases, it's the staphyloma getting bigger. And so the eye's just stretching and the retina can't keep up. And it's very hard to fix that. There's 2 main, the observation. You can do vitrectomy membrane peel, or you can do macular buckle. Macular buckle cases do really well, and it's just not available in the US. We don't have macular buckles.
I was like, I've never heard of that before.
Yeah, there's a device you can get in Europe. It's this little thing it's like it curves, almost like you took your finger and then the tip has a little bump on it. And you put it on the eye and it kind of pushes the macula, and it's not a hard surgery. I tried to do one. There's a way you can do it. It didn't work well. The patient had double vision. It was like miserable. But there are vitrectomy membrane peel, they can do okay. There's some papers having 90% success rate. If you do this, you're not supposed to peel the fovea. And there's a recent paper this month saying where you should probably put an ILM flap down. And the ones with the ILM flap actually did okay. I have not operated one of these 10 or 15 years. I just watch them. I hate these cases. Yeah. And this is one of the only cases where there's actually Tom Ward's really nice. He's a retina guy up in Brooksville. We work together periodically, not together in the group. We share patients, and him and I are like fighting. Like, you do it, no, you do it. It's like, I don't want to do it. He said, patients, is a worsening fractional maculopathy. And the other thing with these patients, I'd say I have a guy now who has this. He's so old, I'm not operating him. But the other thing that comes up with these patients is if they also have wet macular degeneration or myopic. So I have a guy I'm injecting, because it looks kind of like wet macular or myopic, but I'm not sure it's not just fractional macular.
For an island flap, you just take it from somewhere else, and how do you stick it like?
Oh, no, you just peel. I'll show you, I have macular hole surgery. So basically what I do, which is not hard, is you just peel and leave it. And then it kind of flops over.
Oh,
And you just don't take it off the center. So you peel, you leave the center. It's hard because your instruments all try to suck, they all suck. So they all pull stuff. So if you get anywhere near it, it'll pull right out. So you have to be real gentle with it, but most of the time you do that. There are ways to try to do ectopic line. I've never done that, and I don't know. There's all sorts of things you can do when you don't have IOP. So macular hole, male to female ratio is 2 to 1. It's not 90% female, it's about 70, whatever that 66% female. So it's predominant female, but they're not that rare in men. Bilateral, about 10%. And they usually come on with PVD, so it's another PVD disease. Stages of macular hole have been around forever. So these are gases stage. Stage 0 is persistent foveal attachment. Stage 1 is a yellow spot or a ring with foveal attachment. Stage 2 is a small hole. Stage 3 is a fully developed hole with no PVD, and stage 4 is with the PVD. And for this, it's this staging, the PVD is just any PVD. It can be released off the fovea, which doesn't make sense. There's another staging which is not caught on. I'm not even going to show you, and I don't think it's even in the book. But it's a really good staging system. There's a staging which has whether or not there's traction, how big it is, and that's probably a better staging system. But it's like you know, the keyboard and the Amsler grid and the visual acuity chart. I don't, you know, things just stick. Path dependence. So this is stage 0. So stage 0 is same as the stage 2 PVD. The reason I show this is because if this is the fellow eye of a patient with macular hole, there's some papers that show this is a 50% risk without getting a macular hole, which is pretty high. We don't preemptively operate them, but you just have to watch them. Stage 1 is same as grade 1 vitreomacular traction. There's a little bit of pulling, but there's not a hole there. Sometimes the back's pulled up. Stage 2 is a small macular hole, less than 400 microns. Where you measures, you know, there's not a good consensus. I don't measure the base. There's some papers people talk about measuring the base. They'll talk about large macular holes and they use this measurement. I don't think that's right. Usually we use this measurement, or actually even this measurement, which I didn't use in this one. Generally, I use the closest one. I'm not sure why I measured there. The other thing if you're going to stage macular holes is you got to do a detail scan. So you can't just do your plain hole. If somebody has a macular hole, it looks like they might have a macular hole, you have to do this scan. I had a patient see like the most famous macular hole surgeon in the state in Miami who said they didn't have a macular hole. I was like, you have a macular hole. He's like, the other doctor said I don't. So I gave him the scan. I said, here, bring this next time you go in. There's a macular hole there. So so you can miss macular holes unless you do a detail scan if they're small. But you also can't really stage them because sometimes it's just a little bit, you know, right, you have to get right there to stage it. You know, here it looks like, you know, there's the stage 1, right? And then that's a stage 2. And that's it. Actually, that's more of a stage. Yeah, see, that's tricky. Would you do that stage 2 or stage 3?
Based on that measurement, I'd probably stage 3.
Yeah,
It
I
really
don't know.
depends on the cut.
Yeah, and it depends on if you
Kind of
measure
order.
there. Yeah. Anyway. Hold on. Let me cast this.
How long ago did the patient see that other doctor? 'Cause I mean, they can evolve.
No, after me.
Like right after?
Yeah.
Oh, after you.
After
Oh,
macular.
okay.
I was going to see the other doctor. I said, see if he wants to operate your macular hole. Is this better eye? He wasn't seeing that bad. You know, it's a very small macular hole. He said, I don't know if you would see surgery. Asked him what he said. He said, I don't have a macular hole. So I was like, okay.
Watch those a little bit.
Oh, yeah. And then this is stage 3, fully developed macular hole, no PVD. And this one, I think I have a video. Yeah, this one I just don't. So this is a guy I did the other day. I wish this was better focused. Have you seen vitrectomy? We used the small trocars. Kirk Paco came up with this. I saw an interview with him. His idea was to do in-office vitrectomy. Which never caught on, but the things that, so basically you do the same thing you do with the other one. Look at this traction on the, right on the vessel. It's on the bottom of the screen, the inferior vessel right here. Look at that. Isn't that scary? So it's just I mean, there's so much traction to the side. So if I kept pulling, I probably would have avulsed that. So I just go somewhere else. It's remarkable how that works. So you start pulling over here and then you'll see this kind of lifts off. Just it's a different angle. So it pulls off. That works with diabetics too. And then, you know, when you have that much traction, you tend to get all these holes and detachments. Ashley had one of these cases. She said, do you ever get those macular holes where you get a bunch of tears? So there's an inferior detachment and there were a bunch of tears superiorly. This is the tissue glue I was talking about. So you can see that you stain it, you go in with this little loop and you kind of, you know, make a little edge for yourself. And then you grab with forceps. I was gonna leave a flap on this patient, and you'll see what I didn't because it came off. I would say probably 90% of the time I can leave a flap if I want to. So basically, you're just peeling the ILM. It's pretty fragile. This isn't the best forceps for peeling ILM. They pulled it already. So I would normally leave it there, but then it just came off. So I took it out.
So you like partially peel and then you
Just let
flip
it
it
fall
over
over.
and it
It just falls. If you,
Mhm.
yeah, at the fluid air exchange. I peel it 360. I just leave a little vase. And then I just let it fall down as I'm doing the fluid air, but you gotta be
Okay.
careful not to get near it, because it'll just suck right
That-
in.
oh, yeah, right.
It comes right out, and then you laser the tears and put it against it.
Mm-hmm.
It's interesting lasering after you use tissue glue. I don't know if that's the best idea, and then you bend. But you have to use tissue glue to peel the macular hole, and I'm not gonna peel under air, so anyway, so you have to. And this is another detailed scan of stage 3 macular hole, and they get drusen in them. And then this is a fully developed macular hole, with a PVD. It's a little weird. You can have a small macular hole in a PVD and it's still a stage 4 by this staging. Well, it's fine, it's not a perfect staging. And then there's variations of macular holes. So this was a 600 micron macular hole, measured at the closest point. And I did this one with a flap. So this patient's vision, the other thing that's nice is when you look back at your charts, it's nice having some of the details. So you see the person 6 months later, the 2200, it's disappointing. And then you say, oh, I remember, you have 600 micron hole. That's about as good as you're gonna get. With macular holes, if you can picture them closing, they tend to close. It's kind of like a drawbridge. This is a lamellar macular hole, which one of you guys talked about very nicely. So there's 3 requirements for a lamellar macular hole. Irregular foveal contour, which is pretty common, a foveal cavity with an undermined edge, and apparently loss of tissue. So if you don't have the undermined edge, it's hard to call a lamellar hole, sometimes just never done them right. This is a patient I just saw. So this is MacTel, and on top is October 23, and on the bottom is October 24. She didn't notice much of a change, but her vision dropped, I think, from 2040 to 2080 or 2100, and she's got a tractional macular hole. So I am gonna probably operate this patient, but these patients you gotta be real careful with. I've only had 2 real macular holes in MacTel patients, this one and one before, and the patient I did before did okay. So if it's not an atrophic macular hole, if it's a tractional macular hole, then I think they can do okay. With observation, small stage 1 macular holes commonly get better, stage 2 macular holes can get better. This was a weird patient. I actually asked her if she had done poppers. She came in with the top one because the top one looks like solar maculopathy or poppers, but there was a little bit of traction. She had not done that. So this was back in 2023 last year. And then she opened both of them. The right one opened in about 3 months, the left one opened in about 6 months to stage 2 macular holes, and then they both closed. So you can watch these when they're small like that. I think it's reasonable to watch a macular hole for a month or 2. There's a thing now about anti-inflammatory drops. So the anti-inflammatory drops for macular hole are 3. You do 4 times a day Pred Forte, 4 times a day Ketorolac, and 3 times a day Dorzolamide. And with that, they had 70% of the small holes closed, 25% of kind of the medium, and this isn't staged, this is just by microns, none of the big holes closed. So basically, so if you have a kind of smallish macular hole, and my understanding is, and the thing is, this doesn't have stage 1 and stage 2, so I don't know that this really is better than natural history, because stage 1 holes, no, I guess it is, because only 50% of stage 1 holes closed. So I think there is some evidence. So the nice thing is, if you're gonna watch a macular hole anyway, you can put them on drops nowadays, and it's probably not a bad idea to see what'll happen. Also, it gives you time. I like getting their cataract out. I like making them pseudophakic, so it gives me time to have them see a cataract surgeon pre-op.
And if they're on that, then maybe it'll help with.
Yeah, the cataract surgery. So it drops, and most people are okay with it. Macular hole surgery, the book says, for stage 2 or higher, macular hole surgery is indicated. Success rate's very high, it's 90%. I wouldn't say 100% to anybody for anything, but it's close to 100% if you do everything on a small hole. Positioning, I told my fellow doctors on this. Well, basically, you want the bubble to be on the macula. So if you're looking down, the bubble's on the macula. If you're looking straight ahead and you have anything bigger than a 60 or 70% bubble, the bubble's still on the macula. So you really don't need to be face down. All the face down stuff I think is unnecessary. I do face down for 2 hours and then I do straight ahead. And by straight ahead, it means whatever position they're lying, if there's a line straight ahead, you're looking at or below the line. You can watch TV, you can look down and read. When you're lying on your side, anytime you're lying anywhere, your eyes are looking straight ahead or down. You can't be looking up. Having said that, here's my group. I'm 2 hours face down, no face up for 7 days. I always use C3F8. I find that some of the times it doesn't work to SF6. Having said that, I talked to Neil Kelly, Wendell and Kelly were the initial people. I knew them from Sacramento. I was talking at a meeting. They never use C3F8. They always use SF6 because so the people who invented the surgery always use SF6. I find with SF6, I get a couple of failures, but who knows if it's real. One of my other partners, if it's small hole, they use SF6, 3 days face down, and then 3 nights side to side. Large holes, they do 5 days face down, side to side sleeping. Someone else does 3 days face down, sleep on the side at night with C3F8. Someone else is 3 to 5 days of strict face down, then face down as needed. Oh, if you negotiate, say, can you do it? And then someone else is 7 days of face down or either side down. So that's what everybody does. So it's all over the place. So I'm sure your attendings are like all different for what they do for macros. But I like, and the other thing with mine is I almost always try to get them made pseudophakic before. So I try to get someone to take their cataract out before I do the macro surgery. So stages of macro hole, there's 0, 1, 2, 3, 4. And that's it. So I just don't want to cover all the other stuff. You guys can read about it. Maybe we'll cover it in a couple of years. We try to do half the book every other year. I think floaters is kind of interesting, but it's not much in the textbook. We covered all this stuff. Any questions about the vitreomacular traction?
Okay, here's one question.
Yeah.
When looking at the OCT macula,
Mhm.
I was recently told that if you can see the posterior edge of the hyaloid, someone told me that that was the premacular bursa. But it seems like you're saying that that actually is, if you see the retina and then you see the hyaloid, then that means that you diagnose a PVD through the OCT.
Oh, if it looks like that, yeah. If he looks like these pictures, that's a DVD. But sometimes it doesn't. Sometimes, like if you look at the initial one, hold on. Yeah, it's all the way back. If you look at the initial one here, the stage 0. I mean, that's the premacular bursa. Here's the edge of it here. So that's the premacular bursa kind of. This. So there's the edge of it right there.
Okay. Smaller than I thought it would be.
But it's, yeah, but it's not, but that's the back of the vitreous.
Yeah.
But then that's the back of the vitreous. But the premacular bursa is here, so that would be the premacular bursa. But yeah, if it's bright, it's the vitreous.
Thank you.
Sure. Right.